Good afternoon. Today we will be discussing about hypertension. Hypertension, commonly called as a silent killer, it's one such non-communicable disease which silently kills an individual. It does not manifest until late. The complications arise much before a person is aware of his blood pressure status, and hence this disease is called as a silent killer. It's a chronic disease which plays an important role in various cardiovascular diseases like coronary heart disease, stroke, and other vascular complications. It is a condition characterized by an increase in the arterial pressure. And because of this increase in the arterial pressure, the clinical manifestations arise and appear. It's the most common cardiovascular disease all over the world, and it's a disease of major public health concern because, as I said, firstly, it is a silent killer and it causes various cardiovascular mortality, which accounts for around 20 to 50% of all the deaths. It represents a quantitative deviation from normal, that is, that the normal BP, the normal blood pressure, tends to increase when there is hypertension, and that increase in the blood pressure is a quantitative measure. That means it can be measured. Something which can be measured is quantitative. It is measurable. We can measure. By the measurements, one can say that the blood pressure is increased. So ideally, there is no specific definition for hypertension. The definition is arbitrary. Sir George Pickering gave the concept that blood pressure in a community is distributed continuously with no separation between the normotensives and the hypertensives, meaning by that there is no specific or no clear line of demarcation between the normotensives and the hypertensives. The population is evenly mixed. So the distribution of the population, the distribution of blood pressure in a population is in this form of a bell. It's bell shaped. That means it is normally distributed. So how can we divide the population into being normotensives and hypertensives? That is possible only if there is an operational definition or an operational classification or specific cutoff levels are designated. Once there are cutoff levels, only then an individual can be labeled as being a normotensive or a hypertensive. Now, one such classification is the WHO classification. As per the WHO classification, an individual is considered to have a normal blood pressure if the systolic blood pressure is less than 120 millimeter of mercury and the diastolic is less than 80. Systolic BP of 120 to 139 mm of Hg or the diastolic blood pressure of 80 to 90 is considered as a pre-hypertensive stage. There are two stages of hypertension, stage 1 and stage 2. Stage 1 is the stage wherein the systolic blood pressure ranges between 140 to 159 mm of Hg or the diastolic blood pressure is 90 to 99. That is either of the two. Either the systolic blood pressure has to be 140 to 190 or the diastolic blood pressure has to be 90 to 99. Then for stage 2, the systolic blood pressure has to be more or equal to 160 mm of Hg or the diastolic blood pressure is more or equal to 100 mm of Hg. Then there's a term called as isolated blood pressure. Isolated blood pressure is a condition wherein this systolic blood pressure is 140 mm of Hg or more and the diastolic blood pressure is less than 90 mm of Hg. So it's the systolic BP, the systolic blood pressure that is raised and the diastolic blood pressure is less than 90. Then we can say that the individual has an isolated blood pressure. Now, what does this blood pressure do? What does this increase in the blood pressure do? As the blood pressure tends to increase, it causes multi-organ damage, right? So this organ damage, it's correlated with the level of the blood pressure. And such damage varies from individual to individual. It's not necessary that a person who has hypertension will have an organ damage, but most of the times people who have a raised blood pressure, they might have organ damage. And the mechanism of this organ damage in one individual as compared to the other is not clearly understood. Another classification is JNC 8 classification. JNC stands for Joint National Committee. This committee classifies the category of individuals into hypertensives, or it sets up basically the levels of the blood pressure which is considered normal for a particular age group. So this JNC 8 classification is given for the protection, evaluation, monitoring and treatment of blood pressure. Here, according to this classification, a patient who is more or equal to 60 years of age should have a systolic blood pressure of less than 150 and a diastolic blood pressure of less than 90. Individuals less than 60 years, the target blood pressure is less than 140 systolic and less than 90 of diastolic. Individuals 18 years and more with comorbidities like chronic kidney disease and diabetes, for them the target blood pressure has been set at the systolic blood pressure of less than 140 and the diastolic blood pressure of less than 90 mm of Hg. Once the BP is being taken, there can be certain errors which can arise. So these errors will result in misreading of the blood pressures. The errors which are commonly encountered during BP measurement are the observer error. Observer error arises as a hearing acuity. A person is not able to hear properly. Then interpretation of the cord cross sounds. For instance, while monitoring the BP, if there is muffling of sounds or a person doesn't hear the S1 sound clearly, so the interpretation for the blood pressure is difficult. The second possible error is because of the instrument error. Maybe their instruments are leaked, or the cuffs are too small, or there is sometimes inflation of the cuffs that result in the error in the blood pressure measurement. Then there is subject error. Subject error is the circumstances in which the person is examined. Maybe the posture is not accurate, the person is not lying comfortably, the arm is not placed comfortably, the person is in such an environment where there is anxiety or stress or fear. The blood pressure measurement can vary and there can be an erroneous blood pressure measurement in such conditions. Ideally, the systolic and the diastolic blood pressures should be measured at least 3 times over a period of at least 3 minutes, and the lowest reading is recorded for further management. Now, coming to the types or the classification of hypertension. Hypertension is of 2 types, essential and secondary hypertension. Essential hypertension is the one which is most prevalent and accounts for around 90% of all the cases of hypertension. But what causes this type of hypertension is generally unknown. The other classification type is the secondary hypertension. Secondary hypertension is one wherein the hypertension is because of certain underlying conditions like tumors of the adrenal glands or congenital narrowing of the aorta, toxemias of pregnancies. Altogether, secondary hypertension account for around 10% of all the cases of hypertension. Now coming to the rule of halves. Now as I said that hypertension is an iceberg phenomenon with major portion of the cases submerged and only a tip of the iceberg or the disease is evident to the masses or evident. So it became evident in early 90s that only about half of the population is aware of their condition. And of them, only about half of these are being treated. And of them, only about half are considered adequately treated. So this is the rule of halves. Only half of the population is aware of the condition. Of the half, only about half are being treated. And of those, only about half are considered adequately treated. Now coming to the global burden. The incidence of hypertension is variable because of consecutive readings in individuals and the various classifications put forth. Now, it's, we all know, a global problem. It occurs throughout the world. Worldwide, it's estimated to cause 7.5 million deaths. In India, it is estimated that 4 to 8% of the population is hypertensive. And this hypertension is on an increasing trend due to the lifestyle changes, that people are becoming sedentary, the lifestyle is changing, they are more and more going into consumption of alcohol and smoking. So these factors are leading to an increased blood pressure incidence. As on 2020, nearly 1 billion adults globally had hypertension, and this is predicted to increase to 1.6 billion by 2025. Across the income groups, the prevalence of raised blood pressure was constantly high with low, lower middle and upper middle income countries. Now coming to the tracking of blood pressure, there's a term called as tracking blood pressure. So this tracking is that if blood pressure levels of individuals were followed up over a period of years from childhood into the adult life, those individuals with high BP initially would probably continue in the same track as adults. Meaning by that, if an individual has high BP during adulthood, there is every possibility, there is a high possibility that the individual might be hypertensive even in his adulthood. That means the risk of being hypertensive in the adulthood is always there. This phenomenon of persistence of rank of blood pressure is called tracking. This knowledge is applied for identifying those children and adolescents who are at risk of developing hypertension at a future date. Now coming to the risk factors for hypertension. Like other non-communicable diseases, the risk factors are non-modifiable and modifiable. Among the non-modifiable risk factors, the factors are age, sex, gender, genetic factors, ethnicity, race. Among the modifiable risk factors, the factors are obesity, high salt intake, saturated fat, dietary fiber, alcohol, environmental stress, and others. Coming to the age. So blood pressure increases with increasing age in both the sexes, with the rise greater in those with initial rise in blood pressure. What tracking said. Then sex. In initial years of life, there is a little evidence of difference in blood pressure between the sexes. At adolescence, men have a higher average level. Later in life, the difference narrows and the pattern may be reversed. Now, coming to the genetic factors, there is a considerable evidence that blood pressure levels are determined by the genetic factors as well, right? And this inheritance is polygenic. Such an evidence has been brought forth based on certain twin studies, wherein the twin studies have confirmed the importance of genetic factors in hypertension. The blood pressure levels of monozygotic twins are usually strongly correlated than that of the zygotic twins. Family studies have shown that the children of two normotensive parents have 3% possibility of developing hypertension, whereas the possibility increases to 45% in children with both parents as hypertensive. And the blood pressure levels among the first degree adult relatives has also been noted to be statistically significant. Then coming to the ethnicity, studies have revealed that higher blood pressure levels are there more in the black community, the black population, than other ethnic groups. Coming to the modifiable risk factors, obesity is one such risk factor for hypertension. The more the gain in the weight, the greater is the risk of having an increased blood pressure. Central obesity, which is measured by waist-hip ratio, an increase in the waist-hip ratio is having a positive correlation with increased BP in several populations. Then coming to the salt intake, increase in the consumption of salt, that is 7 to 8 grams per day, increases blood pressure proportionately. So, it's always better to consume low salt and low sodium diet. So, the lower the sodium intake, the lower is the blood pressure. Besides sodium, there are elements like potassium, which are determinants of blood pressure as well. Then coming to the saturated fat, evidences suggest that the more the fat intake is there is an increase in the serum cholesterol, which further increases the blood pressure. Dietary fiber is having a good effect on blood pressure. More consumption, the more dietary fiber is there in the food, it is inversely related to the blood pressure. The chances of the risk of having hypertension and coronary heart disease is less if the dietary fiber consumption is more. Then alcohol. Alcohol increased consumption increases the blood pressure. Coming to the physical activity, what does it do? It reduces the weight. So as I said, the central obesity plays a role in increasing hypertension. So if there is good physical activity, weight is less, the waist-hip ratio is less, so it has an indirect effect on the blood pressure. Coming to the environmental stress, the various psychological factors operate through mental processes consciously or unconsciously to produce hypertension. So the more the environmental stress is there, the more stressful environment is there is every possible chance that there will be increase in the blood pressure levels. And why is it so? Because of an increased noradrenaline level in these individuals who have developed hypertension. Then coming to the socioeconomic status, in countries that are in the post-transitional stage of economic and epidemiological change, consistently higher levels of blood pressure have been noted in lower socio-economic states groups. That means there is a transition. A transition has occurred. Transition has occurred from the communicable diseases to non-communicable diseases. And in such countries where there is this transition, where there is this epidemiological transition, there is a higher level of blood pressure in the community, especially in the lower socioeconomic status groups, right? Okay, then the other factors are the like oral contraceptives. They cause hypertension because of estrogen, which is predominantly one of the components of the combined oral contraceptive pills. Fine. Other factors additional can be noise, temperature, that can also result in hypertension. Then prevention of hypertension. How can we prevent hypertension? Now there are various strategies, various approaches which can be taken and given by WHO in the prevention of hypertension. Those strategies are the primary prevention and the secondary prevention. Coming to the primary prevention. So, although I say that hypertension can be controlled successfully by this medication, but ultimately it is the awareness, or it is the primary level wherein if efforts are being made, hypertension incidence can be decreased. So what is primary prevention? These are all the measures taken to reduce the incidence of disease in a population by reducing the risk of onset. We have to reduce the risk of onset itself to reduce the incidence of disease in the population. So for this primary prevention, there are two strategies which are adapted. One is the population strategy, the other is the high risk strategy. Both the strategies, both the approaches are complementary. Now coming to the population strategy. The population strategy is one such approach where the approach is directed to the whole population, irrespective of the individual risk factors. Like by just looking at the individual, or by just approaching the individual, there cannot be much which can be done. So the population has to be approached. So why is it so? Because even if there is a small decrease in the blood pressure, the average blood pressure decline, even if that reduction is very minimal, very less, so there will be a larger reduction in the incidence of the cardiovascular complications, say stroke, coronary heart disease, and other factors. The aim of this population strategy is to bring the blood pressure of the community towards the biological normality. That means towards those levels which are acceptable, which are lower, which are set to be normal for a individual or for a population. So there are various approaches which have been put forth, or various interventions, we can say, which are non-pharmacotherapeutic, which have been put forth for bringing about these changes. So one is the nutrition. Nutrition is very important thing. The nutrition which is usually recommended for hypertensives is the DASH diet. DASH diet is dietary approaches to stop hypertension. This is a diet which is lower in sodium and contains foods which are rich in potassium, magnesium, and calcium. Then there has to be a reduced salt intake, wherein the salt intake should not be more than 5 grams per day. Then moderate fat intake, more of fruits, emphasis is to be put on more of fruits and vegetables. And whatever energy is required for the body, only that much should be consumed, or restriction of the energy intake as per the body needs. So what does DASH diet talk about? It says that there has to be fruits in your diet, there has to be vegetables, whole greens, healthy dairy, lean meats, nuts, seeds, legumes, healthy vegetable-based oils. Then say no to sugar and sugar products, full fat dairy and cheese, and rich grains should not be taken. Elevated sodium should not, the levels, that means some foods which are rich in sodium, they should be avoided, and alcohol should be avoided. That emphasis has to be made on weight reduction, which is a potent way or a good way for reducing the risk of hypertension and indirectly decrease the risk of coronary heart disease. Then Exercise has to be promoted again because it leads to decrease in the body weight, decrease in the lipids, and decrease in the blood pressure. Lifestyle modification or behavioral changes has to be adopted, and uh, you know uh, uh, say yoga can be taken, or meditations can be taken up. Then coming to the health education, people have to be taught about and made aware about the risk factors related to their health behavior. Then self-care is important element in the community-based program, wherein the patient is taught how to take self-care, to take his BP, to keep a logbook of his records, and by whenever a person feels that his BP is more, blood pressure is going up, or there is any deviation from the normal, they can always approach and become a follow-up case, and they can keep this record for long follow-ups. Then coming to the high risk strategy, this is again also a part of the primary prevention. The aim is to prevent the attainment of levels of blood pressure at which the institution of treatment would be considered is appropriate if the risk factors occur with very low prevalence in the community. In families with a family history of hypertension, and tracking of blood pressure from childhood can be used to identify the population at risk. Coming to secondary prevention. Secondary prevention consists of early diagnosis and treatment. Early diagnosis or early case detection, wherein again that is through screening. But screening here is not enough. It's not enough unless and until such cases are followed up for the development of hypertension, and thus screening has to be mixed or linked to follow up for sustained care. Then coming to the treatment, its aim again is to provide a ideal blood pressure. Then patient compliance is again a very important component of this secondary prevention, with the treatment of high blood pressure that has to be lifelong. A person has to be told that the treatment is lifelong. One has to comply with it unless and until a patient or a individual complies with the treatment, he can land into multiple complications which are a part of this hypertension. The extent to which the patient behavior is good, like the way he takes the diets or follows his treatment style, so that coincides with clinical prescription. Compliance rates can be, how can that those compliance rates improve? Those compliance rates can be improved by educating the patients, by talking to the families, patients, and the community. Thank you.